Dear audience, dear esteemed chair, I'm sure that those who are wearing glasses in this room have thought at some point of their life to get rid of those glasses and have a better vision. Let me present you my PhD topic, which is about the corneal healing after refractive surgeries, and show you one limitation of refractive surgeries. My name is Szilárd Szalczer. I'm an ophthalmology resident and a PhD student, and currently I'm working at the Department of Ophthalmology, Semmelweis University. And here you can see my team working on this topic. And we have a common vision that refractive surgeries can be done without complications. And for that, we have a common mission to find a topical-used medication to prevent corneal haze. For that, I have two specific goals. The first one is to investigate the safety and effectiveness of different therapies in the prevention of corneal haze after refractive surgeries. And the second one is to investigate the long-term results of corneal cross-linking therapy in keratoconus patients. Let me present you my first topic. Corneal haze is the inflammation and the opacification of the cornea caused by myofibroblast formation and extracellular matrix formation in the cornea. It occurs 2 to 4% after PRK, and it impacts the visual acuity of the patients. It appears within a few weeks and worsens up to 5 to 6 months postoperatively. There are several treatments, for example, intraoperative mitomycin C or cooled balanced sodium solution during the surgery, or a postoperative corticosteroid taper and UV protection. The problem is that there is no international guideline, only institutional ones. The current gold standard therapy is a corticosteroid taper postoperatively. Our aim is to determine the most effective therapy to reduce the development of corneal haze after refractive surgeries. For that, we build the clinical questions. Do different therapies reduce the prevalence of corneal haze? We use the PICO framework, in which the population is eyes after corneal refractive surgeries, and we compared the different preventive therapies, and the outcome is corneal haze itself. We hypothesize that mitomycin C has the highest effectiveness and the lowest side effects. The clinical implication would be that the proper therapy can be done to reduce the development of corneal haze. We have done a systematic search. Here you can see the selection process. We included 25 articles at the end of the research process, and here you can see also the final search key, which is the corneal haze itself. On the first figure, you can see the corneal haze in the merged myopia group. Here we used odds ratios, in which odds ratio below 1 means a lower risk for developing corneal haze. If it's above 1, it means an increased risk to develop corneal haze, and if it's equals 1, then there is no effect. I highlighted the significant results in different time points. For example, in the first months, intraoperative mitomycin C and postoperative steroid taper had an odds ratio of 0.57, and it was clinically significant. It was significant and clinically important result. We can conclude from this figure that mitomycin C-based regimens consistently reduce the risk of corneal haze in the overall myopia group, with the strongest benefit at 12 months. We can see that the mitomycin C only therapy has had the strongest effect at 12 months. In the second figure, we can see the risk of corneal haze in the high myopia group. We defined high myopia in diopters below -6 diopters. Here we used also odds ratios, and we can see that at 6 months and 12 months, mitomycin C only and mitomycin C combined with steroid taper, and also the two-step mitomycin C and steroid taper at the 12 months reduced postoperative corneal haze, and we can conclude that mitomycin C-based regimens consistently reduce the risk of corneal haze in high myopia with the strongest benefit at 12 months. In the third figure, we can see the severity of corneal haze in the merged myopia group. Severity was expressed with mean difference. If mean difference equals 0, it means that there is no difference between the two groups. If it's above 0, then there is so it favors the comparator, and if it's below 0, that it favors the measured outcome. We can see that mitomycin C-based regimens reduce the haze severity in overall myopia with sustained benefit. On the fourth figure, we can see the severity of corneal haze in the high myopia group. We used also mean difference, and we can see that mitomycin C-based regimens also reduced haze severity in high myopia with a sustained benefit. Our study has strengths and limitations as well. For example, we used a network meta-analysis with a rigorous methodology, and we measured the outcome in a dual mode. We used odds ratios and mean differences, and we have clinically relevant subgrouping. Our limitations include clinical heterogeneity, sparse evidence, and subjective haze grading. For a conclusion, we can say that mitomycin C-based regimens reduce both incidence and severity with the most consistent benefit at longer follow-up times, especially in higher risk eyes. And we can say that protocol optimization appears more relevant than simple mitomycin use or no mitomycin use. We can say that the use of mitomycin C is important in a risk-adapted manner, and we should consider haze. We should avoid uniform maximal mitomycin C exposure. The implication for research should be that we should compare mitomycin C protocols directly, and we should have a standardized haze grading reporting in these studies, and we have to stratify them by myopia severity and ablation depth. Here you can see the manuscript status. It was submitted in a D1 journal called Ophthalmology. My second topic is to investigate the long-term effects of corneal cross-linking therapy in patients with keratoconus, and it will be a retrospective cohort analysis. Keratoconus is a progressive bilateral thinning and cone-line protrusion of the cornea, which causes severe vision deterioration, and it's prevalent in young adults. The diagnosis and the follow-up is based on the Scheimpflug imaging, and we have several treatments, for example, conservative ones, which can be done by glasses or hard contact lenses, and surgical ones, which can be corneal cross-linking therapy or, at the end, keratoplasty. Let me talk a bit about corneal cross-linking therapy. It's a minimally invasive surgery in which the epithelium of the cornea is removed and riboflavin drops are applied on the corneal stroma. Then the corneal stroma is exposed to UVA light, which causes new collagen cross-links to form in the corneal stroma, and it strengthens the cornea. Our aim is to determine the effectiveness of corneal cross-linking therapy. For that, we build a research question. Does corneal cross-linking therapy prevent the progression of visual deterioration in patients with keratoconus? We will use the PEO framework, and we hypothesize that corneal cross-linking therapy prevents the progression of keratoconus, and the clinical implication is that with corneal cross-linking therapy, the rate of keratoplasty in keratoconus patients can be reduced. To summarize, I have two ongoing projects. The first one will be a systematic review and a network meta-analysis, and the second one is a retrospective cohort analysis. I have some additional activities. For example, I am teaching ophthalmology in English and Hungarian for medical and dental students. I'm one of the responsible coordinator of the Semmelweis Corneal Bank. I'm responsible of corneal tissue sample collecting, and I'm a regular presenter at the Hungarian Ophthalmological Society congresses since 2022, and I won in 2024 second prize at the scientific writing competition there. Let me close my presentation with a quote of Ronald Coase: "If you torture the data long enough, it will confess." Thank you for your attention.
Thank you for the presentation. In your daily practice at Semmelweis University, do you use mitomycin C, or what is the practice at your department?
Yes, in our department we use mitomycin C during the refractive surgeries, and after that we use antibiotics until the epithelium closures, and then we use corticosteroid taper for several months.
Perfect.
I will ask a question. Usually, when we apply steroid-containing creams on the face, they try to warn us not to let it come into our eyes. So, nevertheless, you use steroids into the eyes. So, what would be the side effects of that? Or
thank you for your question. Yeah, so there are corticosteroids which can be applied on the ocular surface. We have more types, for example, soft steroids and hard steroids. Hard steroids enters the inside of the eye more potently. So steroids can have a side effect to elevate the intraocular pressure, and also it can have a side effect of cataract formation, which we are very afraid of.
So those steroids that you use will not penetrate?
They are soft steroids, so yes, they are mainly doing their job on the ocular surface and the corneal stroma.
Thank you. This mitomycin C seems to be an anti-neoplastic, antibiotic type of substance. It would involve side effects as well, or would it?
Yes, so mitomycin C is an antifibrotic agent. We use it to slow down the fibrotic effects of this surgery. So basically, we prevent the keratocytes to become a myofibroblast or a fibroblast, and so they will not produce excessive extracellular matrix. It can have side effects. For example, it's keratotoxic. So if when we use it for a longer period, then it will cause a delayed epithelial closure. These surgeries, these surface ablation surgeries, for example, photorefractive keratectomy, are done by removing the epithelium from the ocular surface. Then the corneal stroma is exposed to the environment, and it will cause pain to the patient. So, and of course, different infections can affect the eye. So if we have a delayed epithelium closure, then it can cause these type of side effects.
Thank you.
Well, anyway, I'm sure it is just my lack of knowledge, because your first project is already undergoing submission, so I'm sure that the reviewers understood, but I didn't understand your first project. So where is this haze coming from? Is it after surgery? What type of surgery?
It is, so we are talking about refractive surgeries, which are like vision improvement surgeries.
The vision improvements,
yes.
Oh, right. When you cut a part of the cornea to improve...
Yes, let's say, yes.
Okay.
So when we use laser on the corneal stroma.
For ordinary human beings, it's not that obvious. So.
Yes.
Your patients are close, so...
and most of them, yeah. So, yeah, and this
mitomycin C.
This mycin is like gentamicin.
No, it's not. It's not gentamicin. It's mitomycin C.
But is it an antibiotic? Because you didn't answer.
It's not an antibiotic. It's an antifibrotic.
It's an antifibrotic.
Yes.
All right. It's just an antifibrotic. Okay. Well, good luck with the paper, and over to Peter.
Thank you. I also have a couple of things, mostly recommendations, though not really questions. And this is more. I'm sorry it happens with you, but it's not directed to you. But in general, I see that most students present here and they describe methodology used, but they don't really describe how they analyze the data. we get to see all the selection processes and domains and whatnot, but the methodology used to analyze the data, which I think is really important to understand what's going on, is lacking. Therefore, it was nearly the last slide of your first project where I realized that this is a network meta-analysis.
I see.
And the problem with that is that I immediately want to see the network then, what you found, what you're comparing, so that I can evaluate what you're saying. And then it makes absolutely a lot of sense. So I think this is, if you present it, especially if you're presenting it to people with lay people like me or semi-lay people in the audience, it would be very helpful if we actually understood what's happening before you tell us that you did that method. That was my... And the other thing that might improve, and this is again not a question, more a suggestion, is, and maybe I missed it in the intro slides, that when you're talking about odds ratios, it's really good if we know the prevalence of the outcome you're looking at, so that I can understand that the odds ratio of 0.5 means it jumps from really, really, really rare to just really rare, or is it really a common thing and it makes a lot of sense? It's just an interpretability question, but I could just maybe highlight it somewhere what the prevalence is.
Thank you.
Okay. Yeah, thank you.
Congratulations, and we kind of agree. So there are a few parts of your presentation that what we discussed for the future. Of course, there is always room for improvement, so that's why we are here. So if I also realized somewhere at the sixth slide that you have a network analysis, and if you go back to any of your networks, it's always interesting in these cases that, for example, if you look at the different follow-up time points, it's like there are different effects. And it's not like consistent. For example, if you see that for 3 months it's better than compared to the 2 months, but the 6 months it's again the same effect. But I think in the one, not this slide, but the previous one, it was more visible that the results are quite chaotic. Of course, I mean, what we can see that this mitomycin, I also had to write in my paper because I cannot pronounce it. So mitomycin C is always the best, so that's for sure. But could you identify any other surgery-related confounders or any other reasons that maybe we can see these differences at the different time points?
Yes, thank you for your question. So basically the heterogeneity in the different measurements are based on the different patient and the different included patients in the studies. For example, okay, we are talking here about high myopia, but so in the included studies, the definition of high myopia differs. For example, in some of them they were talking about -6, and the other one they were talking about -8. And so we had to have a decision whether which definition we will use in the meta-analysis. So but that's one cause, and the other cause can be the different ablation depths in these patients. Ablation depths means that the depths we are using the laser in the corneal stroma, and we are evaporating the corneal stroma. And if we are going deeper, the higher the risk of corneal haze. And the corneal haze development is a continuous thing. So after the surgery, in the first 2 months, we have the high risk of developing it, and then it decreases. And at 6 months, we have also an elevation in the incidence.
How this influenced the grading of the evidence? So how did you grade the inconsistencies, for example, between the studies then?
Yeah, so
you also perform grading, I assume.
Yes, of course, it influenced it. Yes.
So downgraded it.
It downgraded, yes.
And what was the end result? So was it like high, or what is the level of evidence?
So it was moderate to high, basically.
Okay, so based on this, what will you do next week in your practice? How will you change your practice? Getting back to the first question, actually, because you were mentioning that you give mitomycin once, I believe, after surgery or for a short period, and
For a short
go
period,
back to steroid.
we use it for 30 seconds during the surgery, and I would still use it because we have very good results using it.
But so how the steroid regimen is included then? So based on these results, if for example I'm looking at the mitomycin C with placebo compared to actual steroid, we see a huge difference in this outcome, for example. Then why would you continue steroid as well? Or do you? So I'm just trying to understand exactly what the intervention is to see that then basically you need to change practice then.
Okay, so it's a difficult question because at 12 months that we had mitomycin C combined with artificial tears had this good effect was based on a very low number of eyes included on that study. So we cannot have a very strong conclusion based on that one.
Okay, but what was the level of evidence for 12 months?
To be honest, I have to.
So for that, it was not moderate or high, or you would say that for 12 months, then it's low or very low.
For mitomycin C and placebo, it was high. In this
the level
case.
of evidence.
Yes.
I'm just asking why.
I mean the heterogeneity was
okay,
moderate to high.
Okay.
Yes, sorry. And it's a low evidence.
Then it's a low evidence.
Yes,
okay.
yes. Thank you.
Great presentation. As I'm also involved because I had an operation, I'm just asking about the complications. And I see you have 12 months, but like long-term follow-ups, did you read on that? Or do you have knowledge on long-term complications? I experienced some reduction in the quality of the vision, which was expected, but like looking forward, reoperation rate, and just like a general question on this.
It depends on your baseline myopia level, so it depends on that, and the type of the surgery. So here in this topic we were talking about surface laser ablations, but we have also flap-assisted surgeries, for example LASIK. There we have very different and we can have longer duration side effects. For example, in a flap-assisted surgery, we can have flap dislocation, which can very well affect your vision after the surgery, or we can have flap inflammation, which is going between the corneal stroma and the corneal flap, and then that can cause very severe scarring, for example. But PRKs are very safe. Surface ablations are very safe. So there we have corneal haze as a significant limitation.
So if I understand, with the flap surgeries, the haze isn't such as an issue as with this technique. That's
yes.
just okay. Thanks.
And of course, myopic regression, which you were talking about, that your vision is starting to decrease at some point after the surgery. It can cause by also corneal haze as well.